Thank you for coming along, everybody. So today I'm going to be presenting on behalf of my colleague who unfortunately couldn't quite make it to the ESD, Dr. Thomas Crabtree, and I'll be exploring the outcomes in terms of HbA1c, looking at the impact of gender, ethnicity, deprivation and age when we roll out hybrid closed loop in the setting of the NHS in England and the UK, and looking at HbA1c outcomes. These are our disclosures. So in 2021, there was a pilot of hybrid closed loop therapy where it was offered to almost 800 people living with type 1 diabetes in England and the UK. To be part of the pilot, people had to already be on pump therapy, already using the Freestyle Libre 2, and had to have an HbA1c above 69 millimoles per mole. They were offered the opportunity to use any commercially available automated insulin delivery system, and this was run out across 31 adult centres. The Association of British Clinical Diabetologists is a charity, and we launched a national audit to capture the real-world outcomes associated with this pilot. And here we can provide some insights into the outcomes. Tom has led on a publication in Diabetes Care in 2023, which gives you the highlights of the key findings. So from 520 individuals that went across to automated insulin delivery, there was a vast reduction in HbA1c of 1.7%, a 28% increase in time in range, a dramatic reduction in diabetes-related distress, and also an improvement in GOLD score. As a result of this and the decades of research that's gone into investigating the benefits of automated insulin delivery, in England we are in the privileged situation where services are now legally mandated to onboard people to automated insulin delivery if they're a child or young adult, if they have a high HbA1c or problematic hypos, or if they're pregnant or planning pregnancy. So what we wanted to do here was explore the impact of baseline demographics on the HbA1c outcomes. And here we'll look at the baseline versus 6-month follow-up data stratified by some key characteristics such as age, gender, ethnicity, and the multiple deprivation decile to understand the impact of deprivation. So across our cohort of 520 AID users, the age was 40 years, gender 2/3 were female, 7% were non-white, and follow-up was 5.1 months. I've mentioned that we saw a dramatic reduction in HbA1c of 1.7%, or an adjusted change of 17 millimoles per mole. So let's explore the impact of those baseline demographics. On the left-hand side here, you can see that the age had no impact. There's no significant difference based on age. There is also no significant difference in HbA1c change based on gender. When we look at the impact of ethnicity, again, similar reductions in HbA1c, whether you're white or non-white. And then when we start to look at the level of deprivation, this again had no impact. Across the board, there were improvements in HbA1c. So there are no impact from these factors: ethnicity, gender, deprivation, or age at baseline. But we know there's a lot of data out there suggesting that sometimes these factors can influence access to technology. And as clinicians, this is something we need to be really aware of to ensure that these factors do not prevent access to what is life-changing technology. So certainly in England, where I work, we're about to roll out hybrid closed loop therapy to the vast majority of our type 1 population. And our challenge is going to be making sure that that access is equitable. If you don't speak English as your first language, that should not be a barrier to accessing this technology. If you're from a very deprived background and you're struggling to make appointments because you can't afford time off work, this should not be a barrier to getting life-changing technology. We need to be aware of our biases and really think about how we as clinicians work around those biases to make sure that everybody has the opportunity to benefit. We're going to have to think outside the box, and it's reassuring to see that these data show the benefits are universal, the challenge is ours to ensure that we address access. I'd like to finish by acknowledging Professor Partha Carr, who led the NHS England pilot of hybrid closed loop, and of course to all the 31 centres and all the work they undertook in contributing the data to this national audit. Thank you very much.
Thank you very much for the presentation. Are there any questions? Okay.
So I'm just curious, do you think there's the selection bias here of people who are actually getting this may be misleading in terms of all these other factors? You alluded to this, and I wonder if it's really fair to use these data to say there are no differences.
Completely agree. There is a caveat. So, for example, in the UK, these were people already on pump, and we know from the national audit data that the least deprived people are the most likely to access pump. But in the cohort we've got here, there doesn't seem to be a signal, but you're absolutely right. And I think this is where real world data is really important, because we need to repeat these evaluations as we have larger numbers coming through. It's going to be interesting to see how that plays out. But I think the other challenge is, where I work in England, we are going to roll it out, and a challenge has been which groups go first. Everybody wants AID, but we can't onboard everybody at once. So in England, we're onboarding the children and pregnant women first, but there's a lot of unhappy people as a result of that. So there will be, naturally, biases coming through in the data in terms of uptake because of the policy in terms of access. So yeah, it's going to be challenging to interpret that.
No other questions? Okay. Oh, no, one more.
So everybody wants it, that is the patients, but how about the healthcare providers? Do they all want it?
Don't get me started. The healthcare professionals are they're people like me, which are absolute tech enthusiasts, and I cannot wait to change the lives of people living with diabetes. There are people who still don't believe in CGM who are diabetologists. And I think our challenge is to make sure that everybody working in diabetes is confident and competent in closed loop. This can't be one small part of a service delivering closed loop. It's a huge undertaking to deliver this. And I think if you are a tech enthusiast, please do your best to convince your colleagues that this is the way to go.
Thank you so much for the great presentation. And we move